Well, I just got off of a psychiatric rotation with eating disorders, and I remember somebody saying they were interested in like GI stuff. So I tried to kind of incorporate the two, because I think it's really important to remember how psychiatric illnesses can also present with actual like physical manifestations. So hopefully this will be a fun session for y'all and you guys will learn something. Um, but without further ado, let me share my PowerPoint, put it back to where it's supposed to go. Share screen, share, slideshow from beginning. Great. All right. Well, okay. And so, yeah, as always, you guys are invited to actively participate by the chat. If you're most comfortable by talking out the whatever you're thinking, that's also totally fine as well. You're welcome to fill out the SOAP note throughout the presentation or take notes however you want. And then afterwards you can have a quiz. And then of course give some feedback is always appreciated so we can continue to modify what we do to meet your guys' needs and what you want to see and get out of these sessions. So yep, so this, if you guys don't have access to that, let me know. So let's start with our case. All right, so we've got a 17-year-old male. He's coming to the emergency department with a chief complaint of epigastric pain, so like upper belly pain, and vomiting blood. So I kept this very vague, just to give you guys a chance to think about what more you want to know with somebody that's coming in with vomiting blood and some belly pain.
I'd like to know what types of food they've eaten. Has he gone anywhere like tropical recently or drinking any type of uncooked food or uncontaminated water?
Yeah, I love those. Those are great questions. Thinking about some infectious disease type of thing, right? I think that's great. Those are wonderful questions to be asking.
Yeah.
I think, okay. And anybody else have anything to add? Oops. So we've started to think about like infectious disease, maybe traveling, maybe picked up a bug from traveling, maybe from something he's eaten, he's picked up a GI bug. What else? Anything you want to know about maybe like his history? Yeah, drug intoxication. Okay, yeah, that's a good thought. Yeah, like does he drink alcohol? Does he take, does he have prescription drugs that he abuses? Has he taken like a lot of Tylenol recently without like thinking about it or knowing it? Oops. So that's a good thought as well. And anyone who had the flu or a cold, yeah. So any sick contacts. Great. All right, well, those are all some good starting point questions. I love that you guys are already thinking about like a differential and what could be causing this, and then asking the appropriate questions for that. So I'm going to move on to the next slide that shows a little bit more information. It's a little long, but it kind of sets the stage. And so I'll read it because there might be some acronyms in here that I threw in there and forgot to write out. But anyway, so you've got the 17-year-old male. He's got vomiting of blood, epigastric pain. He has some mild confusion. He comes with his mother, and his mother's helping to give the history because the patient is in pain. He's really uncomfortable. So mom's just kind of helping to give some of the history. So when he comes to the emergency department, immediately you put in 2 large bore IVs, which we put in just in case like you need to resuscitate people. But this patient, he's got those just in case, but he's appeared to be hemodynamically stable. Like his blood pressure is good. He's just in a lot of pain and, kind of anxious about that. You send a complete blood count to check a hemoglobin level, and then you send what's called a type and screen, which just matches like his blood type to a donor's blood type in preparation for like if he would need some sort of blood product. Because with somebody vomiting blood, you don't know anything yet about like how much blood it is, like are they, unstable and that sort of thing. So you want to be thinking of these things in your head. So mother, she reports the patient's generally healthy, has no chronic medical conditions, but he does seem to have lost about 10 pounds over the past 2 weeks. And she says a fluctuation in weight is normal for him because he's on the wrestling team at school. So he's like always, going up and down in weight. But over the past 2 weeks, she thinks he's probably lost about 10 pounds. Additionally, she says he's recently getting over a quote unquote stomach bug. She heard him vomiting in the bathroom a couple days ago, and when asked about this, the patient told her he had food poisoning after eating at a buffet with friends. So this morning he woke her up because he was vomiting blood, so she brought him to the emergency department. All right. So a lot of information there, but we have a little bit more context about what's going on, right? All right. So questions to consider. What do you guys want to know now? Anything else that you're thinking about or
I would say I kind of want to know, did he have any other symptoms when she noticed he was vomiting after the buffet? Because somebody seems suspicious about that. As she can only mention he just started vomiting after the buffet. And that happened and he also seemed to be vomiting weeks prior to that. So I'd like to know why exactly was he vomiting before the buffet?
yeah, exactly. That is I like that you picked up on that. Yeah, that's
Okay.
you patients give history and our job is to believe patients because of, patients come for help and our job is to believe them and hear their stories and make them feel heard. But there are certainly definitely situations where, not the entire truth might not be disclosed, right? And this might be one of those cases because the patient's like in pain, but is it because he doesn't really want to talk to us about what's going on? Does mom really not know much? And has he given her like, false information? All of those things are important to keep in mind, especially with young adults, especially with adolescents, because a lot of times, it can be embarrassing to talk about certain things, even things that you might not specifically yourself as a provider assume would be embarrassing to talk about. So those are some things to think in your head. So yeah, that's great. Any other questions or any other things that you're thinking about with the rest of the story? And for context, for some people who just popped in, we're talking about we have this 17-year-old male, and he's coming to the emergency department because this morning he had an episode of vomiting and there was blood in his vomit. So he's like, oh, I should go to the emergency department. And he came with his mom, and he's not giving much of a history, but mom is. And mom said she heard him vomiting in the bathroom maybe a couple days ago, at which time he told her that, oh, I just have this stomach bug. I got it at a buffet with my friends, but he's been vomiting probably over the past couple weeks a few times. Yeah, wondering what specifically his diet was over the week. Yeah, that's a great question as well, because certain foods might trigger, certain symptoms and might certainly lead to vomiting or other GI complaints. If you took any meds for the stomach bug. Yeah. So why are you thinking about like medications?
I guess I'd say certain medications, and certain medications could cause him to have like an ulcer, and they didn't
Yeah,
know. Yeah, especially if
exactly.
he's like
Yeah.
vomiting or like the flu, he probably took some Pepto-Bismol or aspirin maybe, so that might cause
Hmm.
it too.
Yeah. So exactly. That's a great comment too. So I think something that we had talked about a little bit earlier too was like asking about meds and stuff, because vomiting and causes of upper GI complaints and vomiting in the blood, certainly a possibility is that could be caused by having an ulcer. And ulcers in the stomach, can be caused by somebody taking a lot of NSAIDs and a lot of non-steroidal anti-inflammatories. So meds are always a great question to ask. All right, let's move on and get some more information. So we already kind of talked about why we think the patient might be vomiting blood. What do you guys think about his weight loss? Is his weight loss significant? It was maybe about 10 pounds in the past couple weeks.
Yeah, that's a lot of weight to lose in a short amount of time. I'm definitely concerned about that, especially if I was vomiting and she just noticed he just keeps vomiting, like when in the bathroom. It seems like he's might be bulimic. So I definitely
I think that's a great assessment there. Yeah, weight loss over, a couple of weeks, only 10 pounds, only a couple of weeks is certainly concerning. Obviously, in any situation where you see a lot of rapid weight loss, like that could be a lot of causes, but our do not miss diagnoses, like we do always want to think about like malignancy and cancer as an underlying cause. Regardless of if the story doesn't even really fit, that should always be in the back of your mind as something just in case. I think somebody is unmuted, sorry. Okay. Okay. We already got this sort of talk about this. Ooh. All right, a little bit more. So you give him a liter of normal saline. You just do that because you're concerned that like his blood pressure has not dropped like significantly to reflect his actual volume status. But he stays hemodynamically stable at that time. CBC returns hemoglobin is low at 10, but usually we don't transfuse anybody with blood products until hemoglobin is like 7 or below. For like younger people, we might consider the threshold to be like 8. But right now you're like, okay, like he did lose a little bit of blood this morning. We'll just recheck and hold off on the blood administration for now. So he's now settled into his bed. He appears more awake and alert. You ask him some questions and he tells you, I feel generally well. Besides randomly waking up this morning and vomiting blood, there was probably about 2 tablespoons of bright red blood in my vomit. He says he has not vomited since, but he does report a history of vomiting intermittently over the past 2 days. No blood during those episodes because of the food poisoning. He states he has an important wrestling match coming up and he wants to fix whatever is going on so that he can get to practice this afternoon. He denies tobacco or alcohol use and he is not sexually active. And here is the physical exam. Anything we notice on the physical exam that piques our interest or stands out to us?
I notice, even despite the vomiting, there's no abdominal issues. So something tells me it's like something else is going on besides abdominally. So we should definitely do an endoscopy to check his throat because it seems like his esophagus might be punctured, especially with the blood when he vomits.
Yeah, exactly. That's a wonderful assessment again, and of the physical exam specifically. Oh, looks like we got something in the chat. Winces upon palpation not normal. Yeah, that isn't normal. Would want to do a gastroscopy or like, yeah, look at the GI tract with a scope. You guys are like already on top of things. Crazy. I love it. But yeah, this physical exam is like grossly normal overall, besides some like pain in the epigastric region. And of course, that kind of pinpoints us to like, okay, this is localized pain, so something might be going on in this area. And so we'd like to look inside and see what might be going on. It looks like he's hemodynamically stable, blood pressure as well. SpO2 is 98 on room air. And everything else is pretty much grossly normal. So kind of focusing in on this abdominal pain because it's consistent with his history and his other symptoms that he's been having. Okay. So IV access has been established. Again, he's hemodynamically stable, but it's unclear if there's continued bleeding. So you want to perform a study, and you guys already hinted at this, to investigate the cause of his bleeding. So my question is, what is the significance of vomiting blood, and what's the next appropriate study? And we can actually just chat about it now before first learning about upper and lower GI bleeds.
Okay, I guess vomiting blood significant because it means something in the GI system is like perforated, or there's some sort of like obstruction abdominally or the throat.
Yeah, so we're thinking about like anatomically something being either perforated, there being some sort of ulcer or cut, or even worse, like a um disruption of like arteriovenous malformations and like diverticulosis. And basically what I mean is like blood vessels, like rupture of an actual blood vessel. So definitely something is going on inside the GI tract, and that's going to prompt us to take a look at it. And you guys had already hinted at using a scope to do that, but we will get back to that. So first I want to just do a learning point about upper versus lower GI bleeds, because GI bleeds, like somebody coming in, like blood in my stool, blood in my vomit, like it's helpful to have a general framework of where the bleed could be coming from, like upper versus lower, because that helps us with like narrow down our diagnosis, and that helps us tell like what we should do with for the next steps, because you'll do a different thing for either. So upper GI bleeding is bleeding above the ligament of Treitz. So the ligament of Treitz is a suspensory ligament of the duodenum. So I just have like a picture here. And essentially that's just going to show you that like an upper GI bleed is like, esophagus, stomach, like duodenum, which is like first part of the small intestine. And then the lower GI bleed is below this ligament. So it's like the small intestine, large intestine, colon, etc. Well, the large and small intestines are the colon, but etc. Upper GI bleeds are actually more common than lower. And one thing that is indicative of a upper GI bleed for sure is something called melena. And I have a picture of that here. And that's very dark, tarry, pungent stool that really smells bad. And the reason that it looks dark like this, and the reason that tells you that this is an upper GI bleed, is because the blood will change color due to the action of gut bacteria. Okay, it won't be this color if it's like not got very long to travel, obviously out. But if it has time to travel, and if it has time to be acted on by gut bacteria, then this is what is produced. Also, a name for vomiting blood is hematemesis. That's what we call that, because emesis is vomit, and it's often bright red. And there are causes of upper GI bleeds like ulcers, which we had touched upon. Varices. So if somebody has like cirrhosis and they have backup of blood, that can cause blood to be shunted towards like the esophageal veins. And what that does is make them dilated and tortuous, and it makes them prone to rupture. So people that have histories of like cirrhosis, severe like alcoholism and cirrhosis together, like they can, if they come in with a like vomiting blood, a concern for vomiting blood, it's often due to this rupture of these varices. Mallory Weiss tear, that's just a tear in the esophagus that causes bleeding, vascular abnormalities, and other things. A lower GI bleed is bleed below the ligament of Treitz, and usually the stool will be bright red to dark red or maroon. And causes include diverticulosis, ischemia, so a disruption of blood flow to the area that causes necrosis of the gut, and that sloughs off and causes there to be blood in the stool. Vascular abnormalities, again, inflammatory bowel diseases like Crohn's, colon cancer, and hemorrhoids. All right, so what do you guys think is going on with our patient? Does he likely have an upper GI bleed or lower? And what could be the etiology?
I say upper because you said the blood was bright red. So I think it's probably coming from upper, most likely the esophagus. because I know like when you throw up, you kind of burn your throat a bit. So me, especially if you're vomiting for a few
Yeah,
weeks.
exactly. And I can go back to the previous slide just so people can look and see what their thoughts are. Yeah, I think that that is a good thought. Anybody else have any thoughts? Does anybody else agree with upper GI bleed or think maybe lower? What are other people thinking? Upper GI bleed because of the color. Yeah, because of the color. And yeah, I mean, another way like to think of this is that like he is vomiting blood. And I mean, bleeding in the upper GI tract is like closer to that, output, I guess, is what I would say. Whereas if it was lower, it would most likely come out in the stool. So great. And then, so we want to perform a study to investigate the cause of his bleeding. What should we do? What studies should we do? And we've already talked about this a couple times, but. Chat. Are there any procedures that you are thinking of doing? Oh, look, we got something. Yeah, an endoscopy. Great. So we want to look at the GI tract with a scope. Great. So I put in this upper endoscopy. Yeah, that's even more specific. There's, an upper endoscopy is only going to look at the upper GI tract, whereas like a lower endoscopy, or it's also known as like a colonoscopy, is going to look primarily at the colon and the lower GI tract, which is why I put this, kind of flow chart in here because I think it's helpful. If you suspect upper GI bleeding, and we start here on the left, it was just a big picture, so I had to cut it into two. But if you suspect upper GI bleeding, the first thing that you want to do is you want to obviously do your ABCs, and if there's concern for like somebody being hemodynamically unstable, you need to resuscitate as necessary, give blood products if that's needed, all those good things. And like our patient happened to be actually stable, so even though we did put in 2 large bore IVs and did a type-in screen in case he needed blood, he ended up being stable, so we weren't as concerned, about something very pressing. And then from there, you ask yourself, okay, well, now I have, put on these things, I've done some volume resuscitation. Is this patient still hemodynamically unstable, or are they stable? And so our guy was stable. And so we can go directly to the EGD or the endoscopy, the upper endoscopy. And after the upper endoscopy, if you don't identify a source of bleeding, that's when you can go in and do a colonoscopy, because sometimes like you might actually have bleeding like closer to the colon, and it can be detected on colonoscopy and wasn't detected on upper endoscopy. Now, after that, if the source of bleeding is still not identified, then you would consider evaluating the small bowel for bleeding. So while the upper GI tract does, the upper endoscopy does evaluate the upper GI tract and the colonoscopy the lower, there is a part in the middle, like in the small bowel, that is not necessarily visualized as well with either of those procedures. And so this is like if we've already done those and we still can't find it, there are certain things that we can do in certain procedures that specifically will look at the small bowel, because we would likely the patient has like a small bowel bleed if upper endoscopy and lower did not show us anything. So great. And then obviously, once you figure out what's the underlying cause, you would treat the underlying cause. All right, so this is just a picture of the endoscopy. Patient goes in and he has remained hemodynamically stable. So that's why he was able to get the endoscopy right away. And the procedure allows for the visualization of the inner lining of the upper GI tract, so esophagus, stomach, and duodenum. So in our results, an endoscopy showed about a 2 centimeter tear at the gastroesophageal junction, also known as a Mallory Weiss tear. I think it's really funny how in medicine, like we name things like by names and like nobody knows what that means. Like, why can't you just call it a GE junction tear? You know what I mean? Like that would be more self-explanatory than naming it after people, but we're moving towards that a little bit more of like less using people's names to describe things. But um, so yeah, you see this tear at this gastroesophageal junction, and that's the junction where like the esophagus, like the mucosa of the esophagus, which is like stratified squamous, and it helps obviously to like, you know, move the food down, changes to like a different, I think it's like columnar, don't quote me on that because I haven't reviewed the histology of the stomach in some time, but it's different than this stratified squamous because it helps us with like acid protection. So the histology of the stomach is different than the esophagus. That's why in things such as like Barrett's esophagus, where you have a lot of acid, like GERD, sorry, like gastro, like heartburn, it can cause something called Barrett's esophagus, which there again is another person's name. But after so long of having heartburn and having this reflux of acid up into the esophagus, that can cause the esophagus to change its histology to more match that of the stomach. And that means whenever we have cells in an organ that change to become like a different type of cell, that can predispose us to cancer. And so that's just some other like extra learning stuff to think about when we're talking about this area. But yeah, so our guy has like a tear and it's a mucosal tear, so it's not all the way through. If you were to have a tear all the way through, that's called like Boerhaave syndrome, and you would know because there would be air in the mediastinum, in the mediastinal cavity. And so when you would press on his chest, you would hear things like crunching. And these patients are like a lot more unstable than somebody that just has like a small mucosal tear. Okay, so treatment for our patient, he's not actively bleeding, so we don't need to treat endoscopically. If he was actively bleeding, we just go back in with the endoscope and you can do things like inject an adrenaline solution. So that would cause vasoconstriction, which helps to stop the bleed, or do like a fibrin sealant. So you can put like fibrin over the area. Other options, you can do like a band ligation or a hemoclip placement. But our patient can be treated with pharmacological therapy only because he's not actively bleeding. So you give him antiemetics to prevent nausea and prevent further vomiting. You give him some proton pump inhibitors, which suppress acid. If we reduce the gastric acid, that helps promote the healing of the erosions. So that's what we do for our patient. So let's talk a little bit about the etiologies or the causes of this Mallory Weiss tear. Because there's other learning points and other things I want you guys to think about and participate in. So a Mallory Weiss tear, it's caused by sudden severe rise in the esophageal intraluminal pressure, and that results in tearing of the esophagus mucous membrane as well as the submucosal arteries and veins, okay? So it's not it doesn't tear entirely through the esophagus, like I said, but it's just like a tear into the mucosa. So precipitating factors are most often caused by severe vomiting. So if you think of vomiting and you think of like a rise in that intra-abdominal pressure, intraesophageal pressure, you can see why this would predispose someone to having rupture of those walls of the esophagus. So it can also be caused by abdominal trauma and strained defecation, but those are less common. And so because it's most often caused by severe vomiting, then you have to think about, okay, well, what are the things that predispose patients to having severe vomiting? And number one reason for like Mallory Weiss tears and severe vomiting and causing a Mallory Weiss tear is alcohol use disorder or alcoholism. Additionally, bulimia nervosa, an eating disorder, is a cause of Mallory Weiss tear that we see. Okay, so what are some additional questions you want to ask the patient? And this is keeping in mind the most common cause of Mallory Weiss tears, because you guys have already told me some great questions and kind of worked your way to the diagnosis, and you told me how you would want to evaluate it to reach the diagnosis. And now we've treated him. So let's talk about like what other things do you want to ask?
I guess even though he said he denied alcohol use, I'd maybe get rid of his mom and ask him again. I'd probably ask him like, have you started eating more than you usually do? Has your eating habits changed?
Yeah, great. So I think I love that point you made about maybe having mom step out of the room, because that's an important consideration in this patient population, especially is that in any patient population is always to ask, like, are you comfortable, with whoever's in the room being in the room? And, sometimes patients are, especially adolescents, are more apt to open up and talk about some things that they're not as comfortable talking around their parents if you ask the parent to step out of the room. So we could certainly do that and ask him, like, do you take alcohol? Do you engage in activities where there is alcohol involved? And then, yeah, kind of probing a little bit more into, the other cause of Mallory Weiss syndrome, which would be like bulimia nervosa, and probing a little bit more into his eating habits, his thoughts and feelings around food, that sort of thing. So that's what I wanted to ask here. So we've asked him about alcohol use, and again, he denies it, and he hasn't used alcohol. And so what we want to do then is ask him about, eating and eating habits. And one way to do this, especially as like a primary care physician, so like maybe as a general practitioner or an emergency medicine doc, some critical care doctor, somebody that is with these patients but doesn't necessarily have training in psychiatry. What you can do is you can use this SCOFF questionnaire, which is a questionnaire that is sensitive and specific for risk for eating disorders. So you ask them these 5 questions. First of all, like, do you make yourself sick because you feel uncomfortably full? Do you worry that you have lost control over how much you eat? Have you recently lost 1 stone? So this was developed in Europe in a 3-month period. So just asking them about like how many pounds, if they've lost a certain number of pounds in a 3-month period. Do you believe you are fat when others say you are too thin? And would you say that food dominates your life? And a score of 2 or more, just 2 or more, would prompt further investigation and further questioning or evaluation about the risk of an eating disorder in these patients. So yeah, like I said, the answer of yes to 2 or more questions warrants further questioning and a more comprehensive assessment. If you have a further 2 questions, so if you have like 4 right, that actually indicates a high sensitivity and specificity for bulimia nervosa. So I think an important concept here to make, important point to make, is that most people with eating disorders don't approach physicians for help. So often it will arise, like the disorder will be uncovered because something has gone wrong medically, right? So, maybe a patient's lost a lot of weight and they've been passing out. Or maybe like, they've been purging a lot, vomiting a lot, and they have a Mallory Weiss tear. Or somebody like their friends, their families, coworkers, whatever, is concerned about them and it was evaluated, because of that. But there's a lot of stigma around eating disorders, and there's a lot of it's called it's eating disorders. Most eating disorders, not all of them, but most of them are called what we call ego syntonic, which is like the person, it's something important to them, like it is behaviors that are not necessarily what they would label as bad, right? Ego dystonic is like noticing that, like, oh gosh, like I'm doing this thing and I want to stop it, right? Like I need help because I want to stop this behavior. Ego syntonic, it's more difficult to like treat patients who have ego syntonic disorders like this because they don't necessarily want to get help. They don't want to get rid of their problem, even though it is dangerous to them. And so that's why this is, again, like I said, a very important point to make, because there are so many times that patients have medical sequelae as a consequence of their eating disorder, but it might not be uncovered by someone, right? Maybe the Mallory Weiss tear was just seen as a Mallory Weiss tear, and maybe as the physician, you were like, oh, he had a GI bug, like that explains it, move on to the next patient. And so it's important to really think about these things, because, you can honestly help save a life by just, being a little more sensitive to some of these issues. All right, so whoops, it looks like one of them I did not put in animation on, but that's fine. You already have the answer to that one, but we'll go through these. So I want to ask fact or myth and talk about eating disorders, and have you guys answer about what you think. So what about this statement? Eating disorders are typically seen in white, middle-class females, and they're usually around adolescent age. What do you think that is? True or false? False, fact, or myth? False. It looks like, yeah, most people are saying myth. Yeah, exactly. So eating disorders can occur in anyone, ages young to elderly. I think in the media, like we have definitely oh, I don't know who's not muted. Can someone mute themselves? I'm sorry. Who is unmuted? Okay, sorry about that. But yeah, so in the media, I feel like eating disorders typically were often portrayed as like, young, thin, white females. And like as we've done more research, as more people have sought care and there's been more access to care, we've realized that's not the case, right? So eating disorders definitely occur in anyone, regardless of even socioeconomic status, whether or not you identify as male, female, LGBTQ spectrum, like anyone. Okay, so what about this one? Most people with eating disorders have a normal BMI. What do you think? True or false?
Because there's binge eating disorders, so that could change your BMI. You could be really thin and anorexic. So false.
Mm-hmm. Yeah, so so most people with eating disorders have normal BMI is actually true. And when you take everybody overall, most people with eating disorders look healthy when they're not, they can actually be extremely ill. And this is one of the biggest barriers to care, and why I think it's so important to educate physicians about this topic, because there have been studies that have shown that patients will go in and, it's been like a patient who was told to act like they have an eating disorder, like for the purpose of a research study. And they go in and they're a normal weight and they look healthy, but they tell the physician, like, yeah, sometimes I feel guilty about eating, or sometimes I eat too much, I make myself throw up, and there actually have been studies that show that like that's not taken quote unquote seriously, or that they don't pick up on the fact that this person might be at risk for an eating disorder, which is just like crazy to me, right? But a large part of that is because you can't see it, right? They're like, oh, it's, whatever, like she accidentally, pukes, or they don't even like ask more about it, because, it's like, oh, this patient looks healthy weight, good height, they're active, okay, move on. But that's why I think that even in like primary care practices, it's really important to just screen in general for eating disorders, similar to how we screen for like depression and anxiety. Okay. So anorexia nervosa is the most common eating disorder in the United States. So false, binge eating disorder is the most common eating disorder in the United States, which is crazy, because also like we don't talk a lot about binge eating disorder. We don't necessarily understand binge eating disorder as much as anorexia nervosa and bulimia. And on the next few slides, I'll talk a little bit more about it, but it's actually the most common one in the US. So what about this? An eating disorder is a preoccupation with being thin or being skinny.
False.
Was that what was that? Sorry.
think they're always about being skinny. Something they're about control too.
Yeah, so this is false. Yeah, this is false. Eating disorders are very much manifestations of a lot of different factors. So, maybe somebody has undergone trauma and that's just the way that their trauma has manifested, or, just stress, or maybe covering up the depression and anxiety. I mean, there are a lot of different reasons. Interestingly, I think that people think that eating disorders are just like a drive to be thin, and that was like the cause, and that's what started it all. But a lot of times, like, it is society does like pressure women and men, but more so women to be thin. And usually eating disorders will happen in people who already have like this predisposition to, perfectionism, and they will, be susceptible to developing behaviors that are unhealthy. But these behaviors and this like drive to be thin is really more so a manifestation of the disorder once they have it, right? Because the eating disorder like serves as like a coping mechanism. It serves as like an obsessive compulsive type of thing in many patients. And so there are patients, even like with anorexia nervosa, who realize they are too thin, but they can't stop the behavior because the behavior is not about being thin. It's about it brings them comfort to continue to do it. Okay. What about this one? Eating disorders can only contain restrictive behaviors. And restrictive eating behaviors is like not eating. Yep, we see false. Great. Yeah, exactly. Okay. Great job with those ones, guys. We learned some things. Where are we? Okay. So let's just go through real quick with as a learning point, the types of eating disorders. I've already touched upon this a little bit, but anorexia nervosa, broadly speaking, is like having an unrealistic idea about body image and intense fear of gaining weight. Again, those are like manifestations of the disorder, not necessarily the cause of the disorder. There are other criteria too. Diagnostic and Statistical Manual for psychiatry and psychiatrists outline some of those criteria that are needing to be met for somebody to actually have a diagnosis of an eating disorder. But it also is important to note that people can have disordered eating behaviors and not necessarily have an eating disorder, but those things are still important to talk about, right? Because you never know when it could lead to something that starts to disrupt their life and starts to disrupt their health. Bulimia nervosa, it's binge eating followed by purging. So usually these patients will, there's a lot of ways that this manifests. It's like, I don't want to eat all day, then like they'll get really hungry and then they'll eat a ton and then they'll feel guilty and they'll purge by either vomiting or over exercising or skipping a meal the next day or something like that. That's the way that they purge. And bulimia nervosa is pretty similar to anorexia in the thought processes that take place, right? Because a lot of it is like fear around certain foods, guilt around certain foods, wanting to be, thin and wanting to restrict certain foods to meet your body goals or whatever. So the thought processes that go on in both of those disorders are very similar. Now, there's something called binge eating disorder, as we talked about. It's the most common cause of, or most common eating disorder in the United States. And it's similar to bulimia in the fact that you like will binge eat and people will eat when they're not even hungry. They'll feel out of control, eating a large amount of food in a short period of time. And we're not talking about, if you go out to a buffet with friends and you eat, a day's worth of food at the buffet, like that happens sometimes, like that's life. But these people don't feel like they can control like their binge eating, right? They'll eat in secret. They'll go and spend a lot of money on food. And the difference between binge eating and bulimia is that these patients often don't like have any compensatory behaviors, meaning that they don't like purge in any way. And it's interesting because even though these patients eat a lot of food, like they don't always have to be overweight or obese. Like they can be thin. Like lots of people have like very fast metabolisms. So, they might be struggling with binge eating and they might look like they have normal weight. And then there's other ones like rumination disorder, pica disorder, avoidant restrictive food intake disorder. these are all ones that are less common, but also I'm wondering too, part of me, research has shown that they might be more common than you think, specifically avoidant restrictive food intake disorder. Um, I was wondering if nail biting would be considered as a pica disorder. Pica disorder, consuming things that are not considered food. I mean, I mean, like, if you sit and eat your nails, I'm guessing, I mean, sure, like, honestly, if that's the definition of that. And a lot of things in psychiatry as, like, when you label them as disorders, or abuse or whatever, is that the main thing is that this is disrupting daily living, right? So you could be, I don't even know, coloring, right? That's not an unhealthy behavior. But if you obsess over coloring and you start skipping your classes because you need to color a piece of paper, and you avoid hanging out with friends, or you avoid eating, and you avoid doing all these things like taking care of yourself because you're so obsessed with coloring, then that's a disorder, right? Anything can be a disorder. Any behavior can be a disorder when it disrupts your daily life and when it disrupts your health. And so, yeah, certainly sitting and nail biting could be considered a pica disorder. Okay, moving on. So how do we treat eating disorders? So eating disorders, unfortunately, are traditionally, oh, thanks for the info. I was just curious. Yeah, I think that's a great question. I mean, I'm curious too. I don't necessarily know the answer, but I think it was helpful in thinking about, what a disorder means, and the fact that many behaviors it can be disordered for people. So treating disorders, yeah, like I said, unfortunately, they're traditionally viewed as the most difficult psychiatric patients. I was just on my eating disorder rotation, and a lot of the psychiatry residents aren't always the most keen on treating on working on the eating disorder unit, and that's not because they don't care, they don't want to help people with eating disorders get better. That's not the case. It's just it's a very hard disorder to treat, and a lot of that comes from the fact that I said it's like an egosyntonic thing. Many of these disorders are egosyntonic. Binge eating disorder is more ego dystonic, and so is bulimia in a certain case than anorexia is. Anorexia is very much egosyntonic for most people. But you can imagine how like binge eating disorder would cause someone a lot of stress, and they don't want to, be partaking in that disorder. Um, so treatment requires a lot of teamwork. It'll be psychiatrists, social workers, psychologists and therapists, nutritionists, physical therapists, occupational therapists. An entire team will care for the patient, especially if they're on like an inpatient unit. Unfortunately, in the United States, many programs don't accept Medicare or Medicaid. University-based programs like the University of Iowa, where I attend medical school, and where we have an inpatient eating disorder unit, we do take Medicare and Medicaid. But a lot of these like treatment centers that are available for people with severe eating disorders that need like 24-hour care to like break their behaviors and break those habits and start moving to more of a healthy direction. Most of those places are not academic hospitals. They are residential facilities that are privately owned and require private insurance. And so you can see how there are many barriers to care for patients, not just the stigma, but also the access and the ability to afford treatment they might need. So one goal that people have, and psychiatrists and people that are advocates for eating disorders, are to improve the barriers by training primary care physicians to care for people with eating disorders. Because if somebody is at a level where they can be treated on an outpatient basis, training primary care physicians a little bit more about how to manage that and how to help patients with eating disorders would allow for more access, right? And that could help solve some of these issues and some of these barriers. I think additionally too, as we had talked about the SCOFF, that questionnaire, the screening tool for eating disorders, I think that's another important thing that, like, at yearly like wellness checkups for patients, you'll give them like a depression and anxiety screen, just because we know those are very common in people and sometimes we don't pick up on it, so we screen for them. I think the same thing should be happening with eating disorders, because if somebody comes in to the office once a year, they're not going to talk about having an eating disorder. They're just not, so we need to be doing those things to actively look for people who are vulnerable to that. And the reason I think we need to screen is because it's so common. Like if it wasn't a common thing, then that would be a different story. But this is so, 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 so common. So if you've learned anything from tonight, I hope you get a little bit of like passion for like maybe learning more about eating disorders and understanding it, because as a provider, I think like this patient population is huge and mental health as a whole, and they've been long been ignored. And so it's important to, change some of that culture and to educate ourselves so that we can be better providers for people who suffer from eating disorders. Okay, so our patient actually scored 5 out of 5 on the SCOFF, so that prompted further evaluation by an eating disorder specialist. And so, if you're a primary care provider and you're not comfortable with like knowing how to manage patients with eating disorders, you can like obviously refer to a psychiatrist, help your patient find like a psychologist or a therapist who specializes in eating disorders. Don't just like leave them hanging, right? So it is important to know your limitations. And if you don't have training on how to manage these things, like as an emergency physician with, seeing this patient for the GI bleed, it's just important to set up outpatient things and outpatient referrals for him to get the care that he needs. And some risk factors in him were like he was young and adolescent. He is male, but men do have eating disorders. And wrestling, like sports that have an emphasis on like body size and body type, can predispose people to have eating disorders, especially something like wrestling where there is such a strong emphasis on weight. You have to make a certain weight class. There are often unhealthy behaviors that take place so people can make weight before certain, competitions. Like there are people that are just like go outside and run in the heat with a bunch of like sweater shirts on to like basically dehydrate themselves to make weight. And obviously none of that is healthy. And so you can see how it can, predispose people that are already vulnerable to developing these disorders. So that's all I have. Thank you guys so much for participating. You did great. I hope you learned a lot, and maybe at least had a chance to critically think a little bit about this case and about the presentation.